Today to learn a little bit more about the implementation research logic model. I assume a lot of folks who are on the call today were part of the EHE summit that we did here at Northwestern back in October. So you should have some initial familiarity with this approach if you were at that and weren't too overwhelmed by everything we were throwing at you. But for anyone who's new, this will be a bit of a crash course into this new approach. So I'm hoping to be able to at least get people oriented and started and seeing some of the potential uses and ways that it could be helpful to improve your projects. And then a full manuscript and additional resources will be available through the ISKI website. So I'm going to turn off my video and then get started with the presentation. For anyone who is not talking, which should be pretty much everyone but me, make sure that you stay muted unless you do have a question. We'll try to save questions for the end so that I don't get too derailed on timing. So let me go ahead and share screen here and make sure that it actually is working. Brennan, are you okay with this? Do you see the correct view?
Yep, looks great.
Fantastic. So this presentation is about the implementation research logic model. This is a method for planning, executing, reporting, and synthesizing implementation projects. So some suggested citations. This was published as an abstract in the journal Implementation Science based on a presentation that was done at the 2018 NIH Academy Health Science and Dissemination Implementation Conference. There is also an under review manuscript that hopefully will be published in the next few months. There will also be a pre-publication publication of this that is going to be published on the medrvix.org website. The link and DOI and full citation with all the materials will be available on the ISKI website soon. That should be approved and up maybe today, but at least by the end of the week. So check back for that. A number of acknowledgements. I want to just point out two. I have co-authors on the manuscript that have helped really push this forward, which are Dennis Lee and Miriam Rafferty. A number of folks have been involved in actually helping develop it, pilot test it with their projects. I have them listed here. And then funding, I want to specifically point out the Center for Prevention Implementation Methodology that's funded by NIDA, and then also the Implementation Science Consortium, or sorry, Coordination, Consultation, and Collaboration Initiative, or ISKI, which is funded by a supplement to our Center for AIDS Research here at Northwestern, and the MPIs are Brian Mustansky and Annette Benbow. So this is a bit of an overused quote by George E.P. Box, where he says, essentially all models are wrong, but some are useful. And it really begs the question of whether or not we really need another model, given that the field of implementation science is really rife with models, and there are a lot of other models obviously available in other related areas that we might be able to borrow from. But I think it's pretty clear that we do need another model, and this one does serve some unique purposes that maybe others available do not. So logic models in general are often funded by, or often required by funders. And as you know, the new EHE supplements that will be funded this year actually require an implementation logic model. So that's in part why we're doing this webinar. Logic models also help us to integrate the necessary conceptual elements of implementation research, which often involves multiple models, frameworks, and theories. And this is really an ongoing challenge in the field. This can also help us to improve transparency, rigor, openness, specification, and reproducibility of implementation research, which again is also a challenge. So rigor specifically is the strict application of scientific method to ensure robust and unbiased experimental designs, methodology, analysis, interpretation, and reporting of results. And we hope that going through the implementation logic model today, that you'll see that these goals can be met with this method. We also have said that improving the specification of the phenomena in implementation research is necessary to inform our understanding of how implementation strategies work, for whom they work, and under what conditions, basically the determinants and contexts, and on what implementation and clinical outcomes. So actually putting together all of these different pieces is incredibly important. Logic models also really help us to show the testable ways of explaining phenomena by specifying the relations among the variables that also enables us to predict the outcomes that we would expect as a result of the initiative, the implementation project, or the intervention as it becomes widespread. Again, logic models in general really are a graphic depiction that is supposed to represent the shared relationships among various elements of a program or of a particular study. They also can help develop some agreement among diverse stakeholders of the what and the how. And this is particularly germane to implementation research when we are working with implementation partners, community partners, multiple stakeholders within the systems that we work in, as well as outside of those systems. They can also help us improve planning by highlighting any theoretical or practical gaps that may not have been initially thought of. And I'll highlight a couple of ways that this has actually happened in our pilot testing of the IRLM. It can also help us to support the development of meaningful process indicators for tracking. And as you know, a lot of implementation research does involve tracking whether or not early milestones are met so that downstream effects can happen. And I think we'll be able to show that too in today's talk. Logic models can also help us reproduce successful studies, so implementations that work, and it can also help us identify failures with unsuccessful studies. It may be not surprising to folks who have been doing implementation research for a while, but the most recent estimates of reviews of the literature have shown that about 48 to 54% of implementations actually fail. So because we're looking at basically a 50-50, we really need to understand better what makes studies successful and what leads to them not being successful. So the development of the IR logic model, I'm going to go over some uses of the model as well as the actual elements or components of the model, and then how they fit together. So in the development, we started out with trying to use the model in a number of case applications. So it was used in the study of implementing a new model of patient care within a new hospital, a new physical space, and really focused on these as implementation strategies. It was also used in the first 6 months of 3 already funded implementation research projects to plan for and describe the prospective implementation research aspects of the trials. So the implementation logic model was not actually included in the grant proposal, but once it was funded, we applied the model to hopefully help with our planning and execution of those studies. We also applied the IRLM and the later stages of a newly completed implementation research project as a way to sort of summarize the results and the actual things that happened during the project. So this was a retrospective application. We also, again, as I mentioned, we used this in a 2-day training hosted by ISKI for the EHE planning project grantees. And I will today present some post-training survey results to show a little bit about the usability and acceptability of this IRLM. So the structure of the model is going to be, I'm going to go over this fairly briefly. We began with the common pipeline logic model format that is used currently by AHRQ, CDC, NIH at times, PCORI, and of course others like the Robert Wood Johnson Foundation and others. Very briefly, this is what that looks like. The pipeline really covers 5 core elements of resources and inputs, and then activities, which are really kind of the planned work. And then the intended results are the outputs, outcomes, and impacts of the project. We chose this model, or at least to base it off of a pipeline approach, because this is a familiar structure to funders, investigators, many readers of our studies and of our proposals, as well as reviewers. We adapted it to integrate existing implementation science frameworks as its core elements with an eye towards facilitating causal modeling. I have a presentation that I've done where we tried to do an overlay and essentially show the elements of the traditional pipeline model, how they map on to the implementation research logic model. Many of them do. So the old model does work in certain ways, but we also were able to identify a lot of shortcomings with places that implementation research just does not have an analogous overlap in any way with the current pipeline approach. So hopefully that'll become evident. Some theory and elements of the implementation research logic model. So the generalized theory of the IRLM is that implementation strategies are selected for a given evidence-based practice are related to implementation determinants. And these determinants are really the context-specific barriers and facilitators. We also theorize that strategies work through specific mechanisms of action to change the context of the behaviors or the behaviors of those within the context. And then we also theorize that implementation outcomes are the proximal impacts of the strategy and its mechanisms, which then relate to the clinical outcomes of the evidence-based practice. So essentially, the IRLM can aid in the specification of the relationship between these foundational elements, that determinants are related to the strategies that relate to the mechanisms of action, that relate to the outcomes that we ultimately see. So I'm going to go briefly over just definitions of the IRLM elements, but I don't have time to go into depth, unfortunately, today. So determinants, when we talk about determinants, we're talking about factors that might prevent or enable improvements. These are often called barriers or facilitators. These determinants can act as moderators of implementation outcomes, or what we call effect modifiers, which are essentially moderators. They can also act as mediators, indicating that there are links in causal chain or chains of causal mechanisms. This definition was pulled from the Consolidated Framework for Implementation Research, and that's what we'll use today for our determinants element. Implementation strategies are supports, changes to, and interventions on the system itself to help increase adoption of evidence-based practices into usual care. So these are not things that actually directly affect the patients themselves, typically. These are really the things that we do to support the system or the context to deliver the evidence-based practice. Carol Lewis and colleagues, borrowing from definitions of others, define mechanisms of action as the processes or events through which an implementation strategy operates to affect desired implementation outcomes. If you're not talking, try to be on mute, if you could, thanks. In the implementation research logic model, there are a number of different outcomes. We differentiate the implementation outcomes from the clinical outcomes. So the definition of the implementation outcomes are the effects of deliberate and purposive actions to implement new treatments, practices, and services. The other side is the clinical outcomes, and these are the direct effects on participants of the EBP or the patients. So this is really kind of patient or participant level symptomatology, functioning, as well as things like new infections. So the format of the implementation research logic model goes along with its structure, but there are a number of different formats depending on the study design itself. So I'd like to go over a few options that we have for this. So the implementation research logic model as a general model looks something like this. We begin with our determinants. And again, we borrowed from the language of the Consolidated Framework for Implementation Research using the 5 domains, which you can see here are the process domain, the characteristics of individuals involved in the implementation, the characteristics of the outer setting, characteristics of the inner setting, as well as the intervention characteristics themselves. So all these different variables. There are other models that could be used, and I want to be really clear that we are using the Consolidated Framework because it's very familiar to folks, but it is definitely not the only determinants framework that could be used. And because we're using this, should not be confused as an endorsement or a rule that the CFR has to be used. The same for other elements of the logic model. We typically borrowed from what we thought would be familiar and what is fairly common, but it does not mean it's going to be the best fit for everyone's projects. Moving into the pipeline, further right, we then have our implementation strategies. So our strategies are often influenced by the determinants and the barriers and facilitators that exist within the context. We then have the mechanisms where, going back to the generalized theory of the implementation research logic model, we expect that the strategies act through specific mechanisms to influence behavior at the system or organizational level or individuals within those systems. And these lead to our hypothesized outcomes. And as I mentioned before, we differentiate implementation outcomes from clinical patient outcomes. And borrowing from Proctor et al.'s 2011 outcomes for implementation research model itself, we also have service outcomes if those are something that would be relevant to your project. So here's a handy little way of thinking about fitting in current models and frameworks. So here we have CFR. Here we have the ERIC compilation, or the Powell et al. 2012 compilation of discrete implementation strategies that would get plugged into this box. No one yet has a beautiful figure for implementation mechanisms. So I have this generic, cogs as they work to talk about the actual processes through which the implementation strategies are changing outcomes. And then I already mentioned that the Proctor et al. Model was influential in how we defined the relationship between implementation outcomes, service outcomes, and client outcomes. And certainly, more common models as well that could be used here. The RE-AIM framework we've used successfully within the IRLM to talk about the implementation outcomes and the effectiveness outcome at the client level. But there certainly are not, you're not held into any of these particular ones that are recommended today or even suggested. So looking at some alternative formats, we have 4 or 5 different ways to display the data within the implementation research logic model, depending upon certain factors, largely the design for the study or the aim of the study. So for comparative implementation studies, comparative implementation means the comparison between 2, potentially even 3 different arms, and the arms are defined as different strategy conditions. So comparative implementation, one thing that's different than just having implementation as usual versus an active or new strategy is in comparative implementation, this is a head-to-head trial of 2 prospectively designed and investigator manipulated implementation strategies. So you would have here strategy 1 and strategy 2. We do this because you need to clearly differentiate the 2 different strategy conditions, which goes to being able to speak to the internal validity of your comparison. We've also done it where in comparative implementation, sometimes the strategies are fairly closely aligned and not too different from each other. So we've actually had at the top, the beginning of the implementation strategies box, all of the shared strategies, discrete strategies that occur across the 2 arms, and then broke it up as shown here with the specific strategies that differentiate the conditions or the arms, so that it's very clear that there are some that are shared, but here are the ones that are unique and different and would be attributable to any different differential effects that are seen in the trial itself. We also have an implementation research logic model for multi-context implementation of a single intervention. So in certain cases, an intervention may actually involve 2 public service systems or 2 different healthcare system contexts. A good example that actually came from the EHE planning grant work, there is an intervention that is looking at how to connect adolescents who are in HIV care in the pediatric system as they transition to adulthood. How do we actually integrate and use a strategy to keep them connected to the healthcare system as they transition between the 2? So in that case, you would actually have 2 different contexts that may need to have differential description of their determinants, the pediatric and the adult healthcare systems for HIV. And then we also have 2 different strategies that may be involved in each of those contexts because of those differences. This is not to indicate that these are a comparison of different strategies, but that there are strategies that are unique to the 2 different contexts to address the contextual barriers and facilitators. We also have an IRLM for what we call implementation optimization trials. There will be a forthcoming paper about this kind of trial design, the implementation optimization trial. But the idea here is that you may have successive packages or conditions of different implementation strategies that you're then comparing and trying to optimize and continually improve or figure out the best combination of discrete strategies. So in this case, you'd potentially have boxes within the implementation strategies section that shows clearly the different packages, the different conditions, the different comparisons that were done within an optimization trial type design. And the rest of the logic model would stay the same. We also, in our initial clinical application and development of the IRLM, had some investigators that we worked with that really wanted to include the clinical intervention within the IRLM. Right now, we basically have shown models where the clinical intervention, practice, policy, whatever it is that's trying to be implemented, would typically be described elsewhere. That's pretty common, but we did realize that there was a need potentially to include the clinical intervention within the logic model. So we also came up with a couple different versions actually that have the clinical intervention. So as you can see, here are the elements of the general IRLM, and then we added in the clinical intervention. The way that this model works, essentially logically, is that the clinical intervention is selected in part because of the determinants within the context that it's going to be delivered. So depending on what kinds of barriers and facilitators, what kinds of patient needs, et cetera, a particular clinical intervention would be selected. The context and the clinical intervention then dictate which implementation strategies will need to be used to successfully get that implemented in that specific context, which is why there are two arrows leading to the implementation strategies. And then the same logic pathway follows that those strategies act upon certain mechanisms and lead directly to implementation outcomes. And then there are downstream effects onto clinical and patient outcomes. There is that light blue arrow down at the bottom to indicate that there are direct links clearly between the clinical intervention and the clinical outcomes. But we know through implementation research, and usually the focus of implementation research projects is to show how those strategies are helping to implement that lead through the mechanisms and proximal implementation outcomes. Here's a second version of the same kind of model where we split up, just have a different way of depicting where the clinical intervention sits. This is considered V2, but it actually was the first version of it. And then we changed back to this version because it seemed to be a little bit more intuitive following the arrows in a clockwise manner. But this would certainly still be an option to be able to show the relationship of the clinical intervention with the determinants and the strategies that are selected. So getting into actually using the implementation research logic model, we decided to base our suggestions on its use on a series of guiding principles rather than a set of rules. These are very much suggestions and principles that we hope folks will find useful, but they are by no means rule governed or absolutely necessary. We included these as mostly guidance, but also to help people complete these as well as possible, and to help meet the intended purpose of rigor, transparency, and improving implementation research. So principle one is to strive for comprehensiveness. So when we talk about that in relation to determinants, we mean to include all relevant determinants and not simply limit reporting to those that are hypothesized to be related to the strategies and outcomes. And this is in part because we know that certain determinants may actually be important that we did not initially consider. There's also the issue of reproducibility and somebody being able to take a look at what the contextual factors were in a successful trial. And if you don't have a complete picture, there's potential for it to not lead to generalizability or replication. We also suggest that you should note the valence of those determinants. And I'll give you kind of a bit of a reason why in a second here. You could simply add pluses or minuses to indicate whether or not the determinant is a facilitator of implementation or a barrier. But we also think you could use something like Dan Schroeder and colleagues' coding system. So they have a system that indicates the relative strength of the determinant that goes from a -2, which is a strong negative impact, to a +2, which would be a strong positive impact on the success of the implementation. So as you can tell, that really is kind of a significant barrier to a very significant facilitator. And there's places in between that you can get a little bit more specificity than just the regular positive minus. So we recommend doing the valence using things like the plus minus or the -2 to +2 scale in comparison to using study-specific adjectives or changing the name of the determinant itself. So it's really kind of difficult to compare if people are saying things like, this has greater relative priority, or this addresses patient needs, or this provides, we want to improve the climate or have a good climate for implementation. Those are difficult things to actually quantify or to compare across studies. So that's why we're suggesting that a valence system is used. When we talk about comprehensiveness in relation to implementation strategies, we want to list all the strategies in the system. And this is not just the strategies that you are going to introduce, but also implementation strategies that are currently being used and will have an impact on the success of your implementation. Second, you want to indicate and label in some way whether the strategies were in place in the system prior to the study, are initiated prospectively for the purpose of the study, particularly for experimental study designs, because this would be your independent variable in most cases. Whether or not the strategy had been ended up actually being removed as a result of being ineffective or too onerous, or whether the strategy was introduced during the study to address an emergent barrier or supplement other strategies because of low initial impact. So this is where the implementation logic model can be used as a way to sort of indicate process. And this is particularly important for the reporting and executing ways of using the model, not as much for planning, because clearly that's, that is saying what your prospective evaluation plan and implementation strategy plan would be. And again, this is mostly relevant for use during planning as an ongoing tracking system. And again, there's another article that's in process where we talk about using the IRLM as part of an ongoing tracking system. It also can be useful for retrospective application of a completed study and in the final reporting of a study to really make sure that all strategies are accounted for. When we talk about comprehensiveness in terms of outcomes, it's very simple. List all the measured outcomes. This is probably pretty obvious, but there certainly is a lack of comprehensiveness at times in certain reporting of implementation studies where only one outcome is listed in a primary outcomes paper when it seems very clear that other outcomes were measured. So we'd want to include those in the implementation research logic model for comprehensiveness. Principle number 2 is to indicate the key conceptual relationships. So you want to indicate the relationship between the elements in a manner aligning with a specific theory of change for your study. So there's lots of different theories of change, many of which depend upon the implementation strategy itself, or the target of the strategy, whether or not it's directly on physician behavior, in which case you might want to use a behavior change theory, or whether it's at the organizational level, where an organizational theory of change would be more appropriate. You want to provide some form of notation to indicate these conceptual relationships using things like superscripts. I suggest that these are the preferred way of doing it because color coding and arrows can be used, but as you can imagine, when things get very complex, color coding and arrows tend to actually be very difficult to follow and track. You can also use a combination of the three, and we have used successfully a limited number of arrows or a limited number of color codes in addition to superscripts to show maybe the primary outcomes, or if you have maybe like 3 aims or 3 sub-aims around implementation outcomes, you could show the actual causal pathways to achieve those 3 sub-aims. Such notations in the model facilitate reference in text, as in your proposal or in your article, to things like study hypotheses, the tests of the effects, any causal chain models, or other forms of elaboration. And I'll talk a little bit about some of these additional resources. When you present the IRLM using presentation programs like PowerPoint, Keynote, or Prezi, colors and arrows can be really helpful, and animations can make these connections more dynamic and sequential without adding to visual complexity that you would have in a static model. Principle number 3 is to specify critical study design elements. So the first of these is primary outcomes. So you want to indicate the primary outcomes at each relevant level of the study design. These could be at the levels of things like clinicians, the clinic, the organizational level, a county, a state, a nation, depending on your level of randomization and other factors that are relevant to your implementation project. Not surprisingly, the levels of the primary outcome should align with the specific aims of the levels and that are targeted by the implementation strategies. So again, if you have an implementation strategy that targets individual physician change, that should have its own primary outcome at that level. If it's being coupled with an organizational change strategy, there would likely be an outcome at that level as well. Another suggestion is to include the downstream health services and clinical outcomes of an implementation, even if they are not measured, as these are important for understanding the logic of the study and the ultimate health-related targets. And you may be saying, of course I'm going to measure health-related outcomes, but that's not always the case, especially in planning projects and small grants like R03s and R21s, where the primary focus might actually be on those proximal implementation outcomes like acceptability, feasibility, initial cost, and appropriateness. So it may not actually make sense because of time horizon or other limitations of budget and focus to be able to actually measure any clinical outcomes, but you'd want to have them in the logic model to show what the ultimate impact would likely be. Another aspect of specifying the critical study design elements has to do with the actual type of study design. So I'll give a few examples here. So for experimental designs and quasi-experimental designs, you want to clearly label the independent variables, which means the strategies that are introduced or manipulated or that otherwise differentiate the study conditions. Sometimes the actual format of the IRLM, as I mentioned before, like the comparative implementation studies, the way that that is actually designed allows you to do this without labeling them in any other manner. So you break the boxes apart to be able to show here's the differences between the arms. This is really important for internal validity and for differentiating conditions if you have a multi-arm study. If you're doing a comparative implementation trial specifically, you want to indicate the determinants, strategies, mechanisms, and potentially outcomes that actually differentiate the conditions. And this will depend very much on what the actual comparative implementation is. So it may not be relevant for determinants where the determinants may actually be exactly the same regardless of the arm or the condition of the study. But the strategies that are used obviously are different by design. The mechanisms through which they act should be different because the strategies are different. And potentially you might have differential outcomes as well. You might need to use an IRLM for each arm when the implementation strategies either occur across two different delivery systems or are simply very different by design. And we ran into this with a very complex comparative implementation trial. For implementation optimization designs, you want to specify the different combinations, packages, or conditions being tested, quite simply. You just need to show what the process is for optimization within the IRLM. So some additional specification options. So users of the model can specify any number of additional elements that may be important to your study. Feel free to be creative here. Some suggestions we have are to notate elements of the model that have been or will be measured versus those that were based on the researcher's prior studies or have simply been inferred from findings reported in the literature. And we see this most often for the selection of implementation strategies or for perceived determinants. So it may not be feasible when you're putting in a grant to have done all the formative work around the actual determinants and the context, but you may be able to draw upon the literature or draw upon stakeholders to be able to have good guesses about what the context will be like. You also want to indicate when implementation strategies might differ by a level or by units within a study. So we came across this in a number of large multi-site studies that we did, where we found that strategies were not totally uniform across all the units, particularly those strategies that already exist within the systems. So I'm thinking specifically about a project that involves implementation across 6 healthcare systems. So as you can imagine, those different systems certainly have different strategies. They have certainly different contexts, even though the primary implementation strategy and the outcomes are all held consistent to be able to do the actual trial. But there are certainly differences that can be captured within the implementation research logic model. So I want to show you a completed IRLM to get a sense of what this actually might look like. This is certainly a comprehensive, but yet still a somewhat bare bones IRLM. This was completed in consultation with a project that I work on that is the Massachusetts Childhood Obesity Research Demonstration Project version 3.0, which Elsie Tavares is the PI. So in this project, we are implementing a healthy weight clinic for child obesity management. These are within pediatric primary care and involve a number of different people from the healthcare team. So in this case, we knew what the intervention was going to be that we wanted to implement. So we completed the Healthy Weight Clinic clinical intervention box first. We also knew what the implementation outcomes as well as clinical and patient outcomes were going to be that we were trying to hit. So we completed that box second. We knew then too that we were going to be implementing these in federally qualified health centers or otherwise in community health centers that serve children. So mostly pediatric, but also family medicine clinics. So we were able to complete our evaluation and assessment of the context by filling in the determinants. And you'll see that we did use the Dam-Schroeder +2 to -2 valence coding. We then were able to go through the proposal as well as brainstorm with our stakeholder partners what kinds of implementation strategies were going to be needed to implement the Healthy Weight Clinic within the federally qualified health center implementation strategies. So that was our next box that was completed. Not surprisingly, our last box was the mechanisms. This is in part because most of our studies do not currently propose mechanisms or mechanistic actions. So this was one of those projects that was funded before we started to apply the IRLM, and we needed to actually add these implementation mechanisms into the model. So one thing I want to point out is that we used only superscripts within this IRLM. So you can see in the determinants box, every one of the primary barriers that we identified as either -1s or -2s are then connected to an implementation strategy. So you can see that there's paths that follow the superscript A's, the superscript B's, the superscript C's, et cetera, all the way through to the implementation, service, and clinical patient outcomes. And I don't have a lot of time to be able to go through these in detail, but I do want to point out that there may be a one-to-one relationship in some cases between the determinants and the implementation strategy that is being used. But in most cases, that is not true. So you can see that there are the bottom right of the determinants of process. So reflecting and evaluating, we saw this as a potential facilitator, not a major facilitator, but at least some kind of a facilitator. And we felt that we were able to leverage this facilitator through 3 different implementation strategies that are labeled as G, H, and J. So there are these 3-to-1, 2-to-1, 1-to-3 combinations of multiple strategies to address multiple barriers or to address a single barrier. There is no, it really needs to be conceptually driven. It's not necessarily a rule that you can follow here. When we then specified our mechanisms, these mechanisms were specified as having kind of primary pathways as well as secondary pathways. So we felt that the implementation strategy was going to work through certain mechanisms, most appropriately through the primary mechanistic action, but that there would be other pathways in the model that would also contribute to or may be affected by the strategy and that particular mechanism. And then you can see in our outcomes box, there are a number of different pathways, meaning there are a number of different strategies and mechanisms that we feel are going to have an influence on the primary and secondary outcomes. So in implementation, our primary outcomes were to increase adoption and also to evaluate the acceptability and feasibility of the Healthy Weight Clinic, as well as the strategies used to implement it. So that was how we actually differentiated those. And then you can see the downstream effects on the service and clinical patient outcomes as well. So what this could easily do is get turned into causal pathway modeling, can be connected to the actual aims of the grant, as well as other supporting documents that I'll go over in a little bit. But this is a relatively good example of a completed logic model and what it ends up looking like. You can see there is quite a bit of detail. The font does get fairly small, and there are a lot of different paths, some of which would be tested, many of which would not, but they're conceptually relevant. So I'm going to turn the presentation over now to Florence, who is going to talk through a completed logic model that she did for their planning grant moving forward. And we solicited from the group anybody who wanted to present a completed logic model, and thankfully we got a volunteer. So Florence, I'm happy to go ahead and control the screen. Just tell me when to advance the slides.
Go ahead. Okay, thanks everyone. And I have to say that, you know, this is clearly a draft and I'm still learning a lot. Actually, your presentation was really helpful in sort of understanding more deeply what I have to think about. But broadly, many of you know that a lot of adolescents and young adults living with HIV have a hard time transitioning from pediatric HIV to adult HIV care, and that viral suppression and retention drop pretty sharply post-transition. So the purpose of this project was to use the CFIR model to guide a series of qualitative interviews that we conducted with pediatric and adult providers. To be comprehensive, we also included other members of the care team, the case managers who are very close to the patients, the behavioral health consultants, and anybody else as who was actively involved, either on the ped side or the adult side. We are in the process of starting the patient interviews. We haven't done that yet. And the goal is to use these perspectives to inform modifications of existing transitions of care plans from the pediatric clinics, and also get an idea of other strategies or interventions that can be used to improve the transition process. You can go to the next slide. So I spent some time doing a literature review to see if there have been published evidence-based interventions to help with the transition process. And so far, there are studies that have been funded that are ongoing. Some of them are finishing, but nothing has been published yet in terms of an actual EBI. But there is clearly work coming down the pipeline. So what I did is that I did my search more broadly and looked at other chronic disease models. And this model informed the SMART intervention, which is for adolescents who are cancer survivors who are transitioning to adult care. But a lot of things honestly overlap with HIV as well. So the first round or the first sort of circle shows in general sort of sociodemographic factors that can influence patients and their behaviors when it comes to transferring from pediatric to adult care. And in general, these are a little bit harder to act upon, such as, socioeconomic status, culture, etc. But in the middle, you have the patient, and of course, because these are young adults, developmental maturity matters a lot, and particularly for patients who are perinatally infected with HIV, where the long exposure to the virus can also affect their cognitive ability. That's also very important. But in general, the patient's self-efficacy regarding their own disease management, health belief expectations toward transferring from pediatric to adult care obviously matter a lot. And then you have the providers, and again, what we noticed during the provider interview is that there is a very different culture and a different approach from the pediatric providers who are in general more intense and hands-on compared to the adult providers who are not necessarily in tune with seeing that the transition process can be difficult for patients. And here you have parents for kids living with cancer, but for the HIV world, parents are not always a good source of support, but it could be, a friend or somebody else who is there, who provides social support for them. So next. So I won't linger too much, but this is the SMART intervention, which really builds upon a socio-ecological model of adolescents and young adults readiness for transition. And the whole purpose of this slide is to show that readiness is not a one-time event, but it's a process that requires multiple check-ins, ideally a year before the transfer is done, and based on the assessments of the barriers and facilitators and needs to come up with a plan that's specific to the patient for transition. And next. Okay, so obviously my logic model looks very different from the previous one, but pretty much it was really helpful to understand that I have to look at the determinants among the peds concept, the peds context and the adults, so that's a very good feedback that I'll take back. But in terms of the, the intervention characteristics, it's really not one intervention. It's really a process of assessing the needs for the patient in terms of, readiness, in terms of knowledge, of self-efficacy and health beliefs, and then coming up with a set of interventions to help readiness for the transition. So in general, it's multi-level, it's flexible, it hasn't been officially tested in an RCT. Again, there's no published EBIs, but I think this presents a good start in terms of thinking about ways to improve the transition process. And then, so this is sort of on the peds end that the process is being done, but again, the transition, it doesn't address what's going on the adult side. And because again, there's very limited data for HIV, I went off to the general literature where there's a lot of data on the benefits of providing a handoff process in terms of, for example, when patients get transferred from one floor to another floor or get discharged from the hospital to the outpatient setting, how there is a sort of a systematic process where basic information that we think is relevant to patient care is also transferred with the patient. And this has been shown to decrease medical errors. So these are sort of the interventions that I'm thinking about, testing and adapting for this particular project. In terms of the inner setting, which refers to sort of the context where the implementation of those interventions would take place, there are clearly very different cultures and norms across the pediatric and adult clinic side. The outer setting, things that, relating to social determinants of health that affects the patients in terms of poverty, housing instability, stigma and discrimination and social support. And I'll definitely, take the feedback about providing the level of impact, particularly for each of those variables. And then characteristics of the individuals I sort of touched on before, but it's really helping young adults with self-efficacy, with disease management, assessing and helping them with their maturity and their knowledge, because honestly, we just rely on them knowing about their HIV history when they get transferred on the adult setting instead of having something more objective than that. And then for process here, I have support for the pediatric providers, support from the case managers, and also the health department and HHS, which actually published some guidance around transitions of care. Now for implementation strategies, I really struggled with that a lot, but I think the presentation helped a lot in terms of thinking about the barriers and facilitators and making the strategies a little bit more specific. But so far I have multidisciplinary meetings where SMART and the handoffs process would be discussed, involving stakeholders, and this could be through different protocols that could be developed. And then again, this is sort of a fluid process because SMART is meant to be pretty flexible, but this is what I have so far. And then for mechanisms, I think it's really meant to increase the communication between the different health systems on the peds and the adult side, and perhaps through the SMART, when assessing the patient needs, increasing the receipts of wraparound services. But again, I'm not even sure that that's the right mechanism. I think I have to spend more time thinking about the different mechanisms, and perhaps increasing social support for the patient. Now, in terms of the outcome, I have adoption, but I really like the reach, so maybe I'll go back and think about that a little bit, but definitely adoption of the SMART and the hands-off process, the implementation, and perhaps thinking about feasibility as well. And then for service, I had ART prescription and wraparound services, but I think you meant something else by that, so I'll go back and sort of think about that a little bit more as well. But definitely in terms of the clinical and patient outcomes, the goal would be to provide successful transition and increase retention and viral suppression.
Great, thank you. I'm sure we'll come back to this in consultation, but this is definitely a start in the right direction. So jumping back to using the IRLM for different purposes, as we already mentioned, there's a lot of different ways to use this. So in the planning process, we often begin with the known parameters of the study. One suggestion that I have is to work kind of from two bookends of the IRLM. Often we know the context and the outcomes, and it's the strategies and mechanisms, and even sometimes the evidence-based practice are not known. So it's often easiest to work from what we want to achieve in terms of the outcomes and maybe what service system we're in. The other thing that's very common is we know the outcomes and we know the evidence-based practice, but we don't necessarily know the context, the strategies, or the mechanisms. You want to work with community partners and or organizational stakeholders to fill in the strategies that are likely to be feasible and effective. You can pull these from the Waltz et al. Compilation. You also want to posit conceptually derived mechanisms of action based on the determinants, strategies, and targeted outcomes. So the mechanisms often are something that kind of develop over time, but they're important to note early on. In the process of actually executing an implementation project, the majority of your parameters will be known so that you can have a pretty fully filled out logic model. However, through completing the logic model prior to the start of studies, we have found that it really helped to reveal important contextual factors that maybe had not been considered during the actual planning and grant proposal process. We also found that a lot of additional implementation strategies were likely to be needed to complement the primary ones that were proposed. Oftentimes we are proposing fairly complex multi-component strategies, but we don't necessarily think through all of the components of those, or maybe some other strategies that need to be used to actually get those components of the strategy actually implemented. And of course, the mechanisms needed to be added and measured since they weren't part of the focus. This completed IRLM during the executing process really serves as your protocol and can form the basis for ongoing tracking of what occurs, what is altered, deviations from the protocol, etc. When using the IRLM to report the findings of a study, nearly all of your elements will be known, hopefully, especially if it's been done kind of throughout the project. It's a means of showing what happened during the study, and it can help us to have accurate reporting of the hypothesized relationships that were observed. It also can really help us facilitate communication of the findings if it's in a kind of primary outcomes paper or even a process-oriented paper. For the purposes of synthesizing, what we really want to do here is to be able to try to draw conclusions for the implementation of an EBP or of similar EBPs in a particular context or potentially across contexts that are shared and generalizable so that we can provide a guide for future research and implementation. And this is currently being applied in a research consortium that I'm part of. So not surprisingly, the implementation research logic model itself is not going to give all the information that's needed, either for a proposal or for a paper. So we recommend a number of supporting texts and resources for ways to talk about the preliminary data, the measures that you're going to be using. The strategies themselves are going to need more detail about the actor, the temporality, etc. Any paths that are going to be tested and how they're supported by theory. Of course, a description of the trial design, even if you're using one of our alternate formats to sort of indicate what the trial design is, that's not going to be sufficient to actually describe the full trial itself and the comparison. And then whether or not you're using an implementation planning or process model like EPIS, that would typically need to be out external to the IRLM. So very quickly, I'll talk about some acceptability and usability of the model. And these are results from a post-training survey to the EHE planning project grantees. So this was a 2-day in-person summit or training that we had in Chicago last October. There were 132 participants, 129 of which completed a pre-training survey, and then 66 completed a post-training survey, and that's who we'll focus on today. So of those 66, 42 were the investigators, and 24 were implementation partners, and there were 68% female reporting. There were 10 items on the post-training survey that were related to the IRLM, plus one about the general logic of implementation research, and these were generally rated on a 4-point scale of how helpful they were. So the IRLM was rated as either moderately or very helpful in a lot of categories. So you can see here, I'll just go ahead and put them all out and just note a few. So the top ones, I have these rated by, or have them actually rank ordered. So participants really felt that it helped them improve the rigor and reproducibility of their project, that it helped in serving as a roadmap for how the project would actually be conducted, helped them clearly report and specify the project plan, and it helped them to understand the connections between determinants, strategies, mechanisms, and outcomes. And it also helped them identify gaps in the logic of their project. What we also found is that the worksheets that were provided during the summit were either moderately or very helpful in completing the IRLM, reported by 74% of the individuals. We also had 78% nearly that said that their knowledge on the logic of implementation research in general had increased either moderately or very much after the 2-day training. And for those of you who were there, know that the IRLM was very much a central component. At the time of the survey, 44% of respondents, this is about 2.5 months into their 1-year planning project, almost 45% had indicated they'd already been able to complete the IRLM. There were no statistically significant differences between the investigators and the implementation partners on any of the questions. However, the question about planning, reporting, specifying, and knowledge of implementation research logic were slightly higher for the investigators compared to the implementation partners, but these again were not significant. So there are a number of resources available for using the IRLM. There is a quick reference guide, which looks like this, that pretty much provides all of the definitions, as well as some helpful citations, and can be kind of just a quick reference for all of the outcomes, all of the different determinants that you could use to really help you complete the logic model. We also have a series of worksheets. There's a bunch. They have to do with the determinants of implementation, they have to do with the implementation outcomes, and then they also have to do with implementation strategies. So these are just really helpful ways of having all these things at your fingertips as you're trying to complete the implementation research logic model. These will be available on the ISKI website, as well as additional files within the manuscript and subsequent, hopefully forthcoming article that will be available. So just some brief concluding thoughts before we close up today. The IRLM is really helpful in providing a visual depiction of an implementation project. It's relatively brief. It can be done in 1 page for most projects. The usability was found to be high for seasoned and novice implementation researchers alike. And our initial indications show that it could increase the rigor and transparency of complex studies that ultimately could improve the reproducibility of our research. Provides a common structure that I think would increase consistency of reporting, as well as maybe help with reproducibility. And this is a method for more clearly specifying the lengths and pathways to test theories. And testing of theory and implementation research has been something that has kind of lagged behind some other areas. Some of the limitations or drawbacks of this is that this is sort of a simplified format, and that's true of any logic model. There's a need to balance depth and detail when doing this, which you can see in the completed results. The 2 different IR logic models that were completed, there is a lot of depth and detail, but it's also not totally overwhelming, I hope. And we also think that there's a potential for this to inhibit creative thinking if people apply it too rigidly, which is why we ended up landing on a principles-driven approach rather than a rule-governed way of actually completing the logic model and using it. And we're really hopeful that people will be creative and adapt the model itself in ways that are useful and improve their implementation research projects. And hope people that will, when they do that and find things that are helpful, will share those back with us, because we'd really like to continue to have this be a community of practice and a learning community for all of us to benefit. So that's the end of the presentation today. And again, thank you so much for being here. Thank you to Florence for presenting her logic model, and be on the lookout for a number of resources that will be available very, very soon. Some are already available, but there will be more in the next few days even. I think we have a couple of minutes for questions, but that concludes the formal presentation. If anyone has questions, I'm happy to take them. I also know that we're a couple minutes over, so I want to be respectful of folks' time if they need to take off.
This is Dennis Lee. This is not so much a question so much as an announcement. I did put the link to the ISKI implementation research logic model website in the chat function.
Hi, JT. This is Mariano Kanamori. I have a question. So do you think that the 5-page proposal will be like a description of our logic model?
That's a good question. I mean, I think you could use it as one of the pages, or even maybe half a page, depending on how much detail you put into it. And then it could be the resource or your figure, basically, to then expand upon in the rest of your research strategy section and maybe some of the background section.
Thank you.
There is a question about including dissemination efforts as part of the logic model. You could easily, I think, adapt the logic model to more of a dissemination focus. Certainly your outcomes may be slightly different. Looking at more dissemination related outcomes, strategies would certainly also align with dissemination strategies rather than implementation strategies specifically. And then there is still a consideration of context and strength of the evidence and things like that to be able to fill in some of the determinants. But you may not be able to directly use something like the CEPR model for that, since it's not wasn't necessarily designed as a specific dissemination model. Resources to think about mechanisms. There are a number of emerging papers. This is a very kind of hot emerging area in implementation science, but I think there's going to be more papers on implementation mechanisms. Carol Lewis's paper that appeared in Frontiers in Public Health in 2018 that was referenced is probably a great place to start. Byron Powell also had a 2019 paper in Frontiers in Public Health that was talking about a little bit more about implementation mechanisms and how they relate to strategies. But I think this is going to be an area with lots of publications that are going to be coming out over the next year or two. Not helpful today, but it is a burgeoning area. Any other questions, comments?
More of a comment. I think this is really helpful. Thank you so much.
Yeah, of course. And for anyone who is having some difficulty with their implementation logic model, I will say that that is fairly common. It's not an easy process to really think through all of these different components. Even in the process of having done this for completed projects, it is still a fairly time-consuming and takes the heads of multiple people who are involved to really figure out some of these different conceptual linkages, as well as just being comprehensive around the process. So do not despair, but know that hopefully by the end it is a very useful tool once the activity is completed.
And this is Brennan. Just to respond to a question, I see a couple when the slides might be available. I will try to get it done in the next couple of days, so hopefully by the end of the week, as long as I don't run into any technological snafus, I should be able to get both the recording of the webinar and the slides up.
Yep, there will be all the formats that we shared today are available in PowerPoint. There is also a basic logic model that is available in a PDF fillable form. And certainly you're welcome to recreate them in Word or your other preferred program if that's of interest too. Okay, well, we definitely went over, so I guess maybe it's time to wrap up and send everyone on with their days. Thank you all for joining, and hopefully this was useful.